Доброго дня, колеги. Hello.
Hello, dear colleagues.
We promised to start this on time, so we will just start now because it's already 5 o'clock. My name is Anastasia Liuchina, and I'm the author of the non-scary book about life, death, and everything in between, and also the editor of the Empathy and Humanity in Healthcare, the Guide for Teachers. Сергій, може, ви покажете слайд з лінком на наш посібник? Ми
Right now you can see the link on
якраз
our
з
manual.
колегами українськими
So
розробили
together with
посібник,
Ukrainian
можливо, ви
colleagues,
про
we
нього
have
чули.
developed this
І ми, власне,
guide.
зараз
Maybe you
створимо цю
have heard of
лабораторію,
it.
яка
So right
називається
now we are trying
лабораторія
to
емпатії
elaborate the empathy
в медосвіті, для того,
laboratory
щоб
in
теж
medical
ділитися
education
думками,
so
досвідом,
that we
вчитися один
can
в одного,
share
обмінюватися
our
найкращими
experience,
практиками.
our knowledge,
Як ви
share
знаєте,
best
в нас
practices.
іноді бувають
And
українські
as you
гості
know,
на цих
sometimes we
ефірах, а
can
іноді
have
бувають
Ukrainian
іноземні гості.
or
І от
foreign guests on such kind of
сьогодні у
programs.
нас фокус
And
дискусії
today we're going to have
це
the focus discussion
міжпрофесійна співпраця в
that's
медичній
the
освіті.
interprofessional
І
collaboration in
наш
medical
гість сьогодні
education.
Пітер
And
Пайп.
together we have
Пітер
Professor Peter
працює в
Pipe with
Генському
us.
університеті.
He
Я познайомилася з ним
represents
в
Ghent
Генській
University.
цього
I
року.
met him this year in
Я
Ghent,
була абсолютно
and I
вражена
was
його
totally
історією про те, як
mesmerized by
вони
his history, by his story,
започаткували і
how he
розробили програму
launched and
навчання
developed this training program
міжпрофесійної
um,
співпраці.
within interprofessional
Пітер, я так
collaboration.
розумію, що
And
він
Peter,
раніше і
I understand
дуже багато уваги приділяв
that Peter paid a
викладанню
great deal of
паліативної
attention
медицини. Можливо,
to
трошки про це теж
teaching
розповість.
palliative medicine. Maybe
А
he will
зараз
talk
він
about this
власне є
as
одним
well.
з лідерів,
But right now,
які
he's one of
створює
the
і
key leaders
запроваджує цю
who
навчальну
create and
програму з
introduce this
міжпрофесійної
training program
співпраці.
of interprofessional
Ми
collaboration.
будемо зараз працювати в такому
We are
режимі
going to
інтерактивної
work
лекції,
into
тобто
the
Пітер буде
interactive
ділитися своєю
lecture
історією.
mode. Peter will
Якщо у
share
вас
his
будуть цікаві
story.
питання, пишіть їх, будь
And
ласка, в
if you
чат.
come up
А
with
я
a
буду
question,
тоді
please
Пітеру
insert it into the
приносити.
chat, and
Він
then
теж
I
дуже
will
попросив, щоб
read it out
обов'язково
to Peter.
дописати
And he
питання,
also
щоб він
asked
міг
you
теж
not to forget your
вам
questions, but to
відповісти,
write them
трошки,
right
можливо,
away so that we can
додавати,
make
якщо
our lecture more
потрібно. Хто вже
interactive,
він
maybe to
запланував.
add something.
І для мене це велика честь, що він
For me, it's a
погодився.
great honor to have
Я
him
тоді
with us.
переключуся на
And right now,
англійську.
I'm gonna switch
Peter,
into
I will be
English.
switching back to English. And I would like to start with the question. I mean, when we think of interprofessional collaboration, like I can think of doctors or nurses who would say, listen, I have been working for 20 or 30 years. I have done it all. I have spoken to so many people. I've been in very, various situations. What is there to learn? Like, what are you talking about? I am doing it for 30 years. And now you are coming up with this new subject that is called interprofessional collaboration. What is it like? And can you really learn it?
Thank you. Well, first of all, thank you for inviting me to discuss and reflect together with you on this important topic. I'm very happy to be here. Secondly, I do understand your openings question. I am a general practitioner myself. I have been in clinical practice for 35 years, and very often I have the same reflection. I know, I do this. Don't tell me what to do. But then one of my main what changed my idea about this is that I tried not to look at the person talking to me as somebody who wants to tell me what to do, but as someone who wants to learn from me how I am doing it. And then by collecting all the best practices of experienced clinicians, we can capture the essence of interprofessional collaboration and then turn it into education. And so this took away my resistance of that I feel when somebody is telling me what to do. So it's often a co-creation. Someone who has a more theoretical background who is discussing with people who may not have the theoretical background but have lots of experience in the field, and together they can write a new chapter on how to move things forwards. And this is what I will be trying to do today as well. We have our experience of implementing interprofessional education in our universities and university colleges for many years now. But along the way, I have met a lot of people, a lot of teachers who do not have explicit interprofessional curriculum, but they have done a lot of interprofessional things without labeling it as such. And so from these people, I learned a lot and I adapted it into my, let's say, theoretical viewpoints. And so this is a continuous changing insight that we can use to build the future together. This is one aspect. And the second aspect, that is, as a GP, I would say experienced GP, 35 years, when I graduated, and at least in Belgium, the population has changed a lot. People are getting older. There is lots of multimorbidity, more complexity required. Patients are also more informed. They have the internet, they know more, they are more or differently educated than before. So the people, the patients we are taking care for have changed as well. And this is an additional collaboration. So interprofessional collaboration, as I said, there are lots of changes in demographics, in the population, in the healthcare needs, but also in many countries, changes in the healthcare workforce. When there is a lack of doctors, you need more nurses to do the work. And lots of things in healthcare can be done by more than one profession. There are things that a doctor can do and that a nurse cannot do. But there are also things that a nurse can do that a doctor cannot do. And then there are things that both of them can do. And then you need to look at the patient in front of you and deliberate and decide together who is going to do what, so that in the most efficient way we can move the care for this patient forward. And this, talking about who will do what, because some things we can both do. Who will do what, in what order, and how will we report to each other, and how will we monitor our actions in care and discuss with our colleagues. This is the essence of interprofessional collaboration. So I agree. Lots of people are doing it. Lots of people have experience, but it doesn't mean that they cannot keep on learning together with other people. So collaborative practice, people working together, is, as you can see, when multiple professionals from different professional backgrounds work together with the patients and the families and the communities, because they are all in the same team taking care for each other. This is interprofessional collaboration. And we know from literature that when you collaborate interprofessionally, that care coordination can be better, that outcomes at the patient level can be better. We also know that for some subpopulations that may be more difficult to reach as an individual professional, that you can reach these populations when you collaborate with other professionals. And so overall, we know that the quality of care is better when you collaborate. It's also more efficient also with respect to resources. It's a better way to use the healthcare workforce, that you don't have one professional performing a task that maybe another professional from another discipline is better placed to do so. So healthcare workforce, but also costs are lower when you collaborate in an efficient way. And finally, increased job satisfaction and professional well-being. Because at least in my country and in Western Europe, we see a lot of burnout in healthcare workers. And the literature shows clearly that when you collaborate in an interprofessional team, your job satisfaction, your well-being is also better. So we have a lot of reasons to collaborate interprofessionally in the field. And it is even, yes.
Sorry, we agreed that I will ask you some questions along the
Yeah,
way.
of course.
And I just want, we got quite a bit of questions in the registration forms. And I think this one really relates to what you were saying. It sounds like, how is lifelong learning organized in Belgium? And I understand that this may be like a bit very wide, but maybe you could put it into the context of what you were speaking about.
The lifelong learning in Belgium is somehow structured, but not very targeted. What do I mean? When me as a physician, for instance, but also hospital specialist, physiotherapist, and other disciplines, when they graduate, they need to follow some courses on a yearly basis to be able to keep their accreditation, their certification. So every year they need like, let's say, 20 or 30 hours of continuing education to be able to have their certification for the next year. So that part is well structured and well regulated. What is not regulated, that is the focus on quality. Because, for instance, I'm a GP, general practitioner. If I like palliative care a lot and I know how to do it, but I don't know much about orthopedics or musculoskeletal disorders, then it would be interesting to have me follow some courses on musculoskeletal disorders. But this is the part where the lifelong learning is not well organized. I can do whatever I want. So I can use my 20 sessions in a year for palliative care, which I already know a lot about, and still have my recertification. So it is structured, it is mandatory, but the content is not tailored to the needs. It would be great if regulation would say you need at least one interprofessional course, one course on palliative care, one course on communication, and then for the other courses you can make your choice. But now we can make the choice whatever we want, so that, and this is human, I will follow courses on things that I like to do, and usually those are the things I already know. So in terms of quality guarantees, it's not well structured. In terms of having at least a structure that we can fill in, hopefully in the future with better quality arrangement, there I can say there is a structure. Okay. So final introduction slides, the quintuple aim. I think we all have heard about the triple aim. It has been out there for some time. Also, the WHO, World Health Organization, has been talking about triple aim. Well, along the way, we have moved to the quintuple aim. And this is that the 5 dimensions that you can see, the care experience of the patient, the well-being of the professionals, the costs, the equity. So underserved populations need to be cared for as well. And then not only the individual care, but also the population health. And these are the 5 dimensions of high quality care. And it is said that every intervention that you do in healthcare should aim as much as possible to these 5 dimensions. And now we see that interprofessional collaboration is capable of making these 5 dimensions better in healthcare. So again, this is a strong argument to stimulate interprofessional collaboration in healthcare. And now there are 3 main requirements to stimulate interprofessional collaboration in healthcare. One is policies and government. So the government needs to facilitate collaboration with finances, with creating new disciplines, with having disciplines being accessible, with having enough of a certain discipline. So these are policy issues. The second is the health system infrastructure. If I want to collaborate, then I need a nurse nearby. I might want a nurse in my practice. So these local infrastructures need to be in place. But these are things that most of us have no impact on. I cannot call the Minister of Health and tell him to change things. What we do have an impact on, this is on these educational programs. And then in the lifelong learning, we have the continuing professional development throughout our career. And then at least for ourselves, we can try to make the right choices, but we can also talk to the colleagues in our team to make the right choices. But for today, we are talking about undergraduate education. So in the undergraduate education, for all healthcare professionals, we should strive to implement interprofessional education programs. And we do have some support for that. This you can find on the internet. It's in many languages translated on the IPEC website. They have a set of collaborative competencies, because we know that as a physician, I graduate with a set of physician competencies. A nurse is graduating with a set of nursing competencies. A physiotherapist, a psychologist, they all graduate with the right professional competencies. And this IPEC is a framework of interprofessional competencies, meaning this is discipline independent. Everybody who graduates in a healthcare discipline should have these team competencies. Yes.
Quick question. So this sounds like a really high level stuff. And I wanted to check, maybe you could share, how did you identify the need to go there? Because, for example, like in the questions that we have asked our audience, it was also like, what would you teach? Like, in people's understanding, in the professional communication is a lot about working with conflict and having conflict-free environment and things like this. And I assume, and also from what I learned from you, that it's a bit more than not having conflicts in the workplace, and it can be a much wider perspective on relationship in the workplace. Maybe you could say a bit about, like, how did you feel that this is what is missing, and this is where you want to invest, you personally, but also university, to invest your time in?
Okay, good. That's a good question. Well, I was allowed at my university to start to think about interprofessional education. And then I thought I might have only one chance to introduce. So I wanted to do it right from the first time, meaning the bigger picture. It's not sufficient to have like one course in the 6-year medical school. I wanted the collaboration competencies from year 1 to year 6, and I wanted it integrated in the curriculum. So I don't want, for instance, a course on cardiology and then another course on collaboration. I want the professor in cardiology also to talk about collaboration. So I wanted it integrated. And therefore, I needed a framework that covers the entire curriculum. And I'm going to move forward. I'm coming back to the previous slide later on. But this is what I want to show. You cannot read it. It's too small. It's just an illustration. But on the top row here, on the top, here we have put all the courses from the medical curriculum from year 1 from the left to year 6 to the right. And then these IPEC competencies, there are like 40 competencies. Very detailed, very specific. And I have put them on the left from top to bottom. Because these competencies, and you should check out the website, they can be ordered from basic through intermediate and advanced. And so what we have is all the competencies to the left from starting to advanced, and all the courses from left to right. And what we then thought about is we should have basic team competencies in the first year, the first red circle, for instance. And we should have the more advanced competencies on collaboration in the final year of medical school, the last red circle. And so we were able to draw, hypothetically, where in the curriculum we should put some collaboration exercises for the students. And so this is the overall framework that I drew 6 years ago from the beginning. And every time now that we have an opportunity, because when you want to introduce an interprofessional class, for instance, between doctors and nurses, then you need a free hour in the medical curriculum and a free hour in the nursing curriculum to bring the students together. And so we have done this exercise that is presented here for every curriculum. Medical, nursing, physiotherapy, psychology, social worker, speech therapist, everyone. And then we were able to put all these exercises on top of each other. And if we saw, for instance, in year 3 of medical school, there is an opportunity, let's check the other curricula, if they have the same opportunity somewhere in the same spot. And then we could start thinking about bringing those students together. Because this entire set of competencies, you can see them here. There are 4 core competencies: values and ethics, roles and responsibilities, communication, teams and teamwork. And those 4 main clusters of competencies, they each have about 10 sub-competencies. So there are 10 competencies on values and ethics, on teamwork. How do you respect each other? How do you learn to value the views of another professional as well? How do you share the same ethics in looking at the patient? Same with roles and responsibilities. As I said in the beginning, there are some tasks that both of us can do. How do we decide upon who will do it? How do we share responsibility? How do you create a team sense of responsibility and not just an accumulation of individual responsibilities? Same with communication. How to we all know that we should not use jargon towards the patient, not our professional language to be used towards the patient, but every professional has its own jargon. I am using different words than a psychologist and a social worker. First time that I was talking to a social worker, half of the things she was saying I did not understand because she was using her jargon. So also interprofessionally, there are some communication aspects needing to be into account. And so these 40 competencies you can use as an overall framework, saying that by the end of the curriculum, when they graduate, they need all of the competencies. And then you can try to build them into their respective curricula. Yes, please.
Is that okay that I'm interrupting you so often?
Yeah, it's perfect. It's perfect.
So, I mean, I have been in discussions in medical schools, so everybody operates within like really limited number of hours. And basically, there is a belief that people really need to learn anatomy. People really need to learn surgical skills, like some technical skills, pharma, chemistry, like all this hard stuff. And then we come to them and say, oh, and by the way, they need to learn medical communication and how build relationship with doctors. And now we are coming with you and say, oh, by the way, on top of all of that, they also have to learn how to communicate to each other. And for me, the question is like, how do you find time for all of this? Because the number of hours is limited, and I assume that the scope of time that is given to a student in a Belgium university and in a Ukrainian university is probably the same, or more or less. It's comparable. Let's put it that way. How do you find time to cover all of these complex layers of the profession?
You are starting off with all the difficult questions.
I told you.
Yes. But it's a very important question that everybody struggles with. And there is a balance. I mean, you should think big. I mean, have the overall framework and have the ambition to teach all the students all the 40 collaborative competencies. So think big. And at the same time, take small steps. So think big, but be modest. And then I'm talking about low-hanging fruit. For instance, I am thinking about one class where we were teaching medical students about low back pain. And then we were talking to the teachers of the physiotherapists. And they also have one class teaching their physiotherapy students about low back pain. So what have we done? We did not delete and replace with something else because, as you say, curricula are full, but we put the students together. And instead of teaching for 1 hour, we have been teaching for 30 minutes because the theory you can bring in 30 minutes. And then the second part of the class, we had medical students and physiotherapy students talking to each other and doing a physical examination of the back. And then the medical student could tell to the physiotherapy student, well, if a patient comes to me and tells me about his low back pain, I also think about aneurysma in the aorta. I don't know aorta in English. Yeah, I'm talking about aneurysma in the aorta. And then the physiotherapy student said, oh, well, I never thought about this. We don't learn about this. And so without this being the goal competency of the class, this physiotherapy student has learned that he should sometimes also think about other things or listen to the physician. And then they swap places, and the physiotherapy student explained to the medical student how he was explaining to patients how to do exercises for the back. And then the medical student said, well, what you are telling me now, I never heard of, because we only learn about 2 or 3 tests for clinical examination, but the physiotherapy student knows about more of the muscles and the function of the muscles. And so by explaining to the medical student how he shows to the patient how to do the exercises, the medical student first learned about anatomy of the low back muscles, and secondly, he realized that as a physician, he doesn't know everything, because some medical students do think they know everything. So without changing curricula, without lots of logistical implications, just bringing 2 students from 2 disciplines who are having the same class in their own curriculum, we bring them together, we have a joint class, no extra hours, no extra teachers, but the students teach themselves respect, communication, how to listen to each other, how to adapt their language, because they have a different jargon, and to explain to the student from other discipline what you mean, you need to adapt your language. So many of these collaborative competencies, the student teach to each other and not the teacher. The teacher just facilitates by bringing them together.
So, and we also have the clarification questions. I think you are going with it also, and I think maybe some slides are here as well, but the question from Irina, who is leading this classes? So like which professor would lead the class? And also what kind of activities do you use during these discussions? Or maybe you could share some instruments, and how many students do you have in the group? Like maybe this is too much into the details, but people are curious.
No, it's interesting, and I'm happy with these questions, because when you will share the presentation with the participants afterwards, so they can read, because the first part of the presentation is a theoretical part, and the second part is then how we did it in Ghent, and maybe your questions are on the second part, but I will answer them now. And then the first part you can read later on, or we can discuss later. So build a coalition is very important. You need believers. And then secondly, design the master plan. That's what I said. Think big. Don't be modest in your thinking, but be modest in your actions at start. And that's the some modules. I will come to your question, Anastasia, later on. Just I want to share this, because I do realize that somehow we have been lucky in Ghent. The dean of our faculty, he said, well, interprofessional education is important, so I'm appointing you professor in interprofessional education. So I had a position and I had my time, and this support from the dean or from the rector is very important. The second what I did is collect the believers. So in every program, I looked for one believer. In the curricula of physiotherapy, I looked for one physiotherapy teacher who was a believer in interprofessional education. In the nursing school, in the psychology school, and everywhere I found one believer. And with this group of believers, we had this strategic core committee. And this is important, because there you make strategic decisions, like this one, where and how shall we put another module. And then we have the planning committee for the operationalization, and this is also important, the stakeholder committee, meaning that we had a large group of teachers from different programs, also for programs who were not yet involved in interprofessional education. But once a year, for 2 hours, we brought them together. And also the programs that were not yet involved. But then every year we had like the good news show, and we explained what we have been doing. And I did not do a lot of explaining. I had the other teachers from the other programs, the believers from day one, I had them tell about their small successes so that they could motivate their colleagues from other programs. So this is shared responsibility, shared ownership, and in every program you need one believer, because I can, as a medical doctor, I cannot go to the nursing school and tell them what to do. But if I have one nursing teacher who is a believer and who stands by my side, I'm having this nursing teacher telling them in the nursing school that it is important. So from inside and not from outside. Then I'm looking for the slides. Yes. So we have different kind of modules. This should not be model. I made a mistake, but module, like class or course. We have new modules and existing modules that we adapted. For instance, the module on low back pain, that was an existing model in the physiotherapy school and in the medical school, and we adapted it a little bit by putting them together, and now we have an interprofessional module. So this is a quick win. In the new models, again, think big but start modest. We have what we call the awareness class. And now I'm coming to your question. LISA is Dutch acronym for Learning to Collaborate Interprofessionally. So every module in every program that is on interprofessionality, we call LISA. LISA awareness, LISA teams, LISA whatever. So that students and teachers recognize that LISA is present. And so every now and then, people talk about LISA so that the game is in their minds regularly. And the LISA awareness is, I think, a very nice introductory class. It's in year one. And what we are doing is we are bringing groups of students together. And for instance, in medical school, now in Ghent, we have a bit more than 500 students in year one. And in the physiotherapy school, we have 450, so large groups. So what did we do? We brought them together in 1 hour and a half online session, 900 students. And we asked the medical students to write down what the first thing is that they are talking about, that they are thinking about when they think about the physiotherapist. And so they type, and then they create a word cloud. And then we put them in breakout rooms, mixed breakout rooms, medical students and physiotherapy students, and we ask them to discuss the word cloud. And then they come back, and from each breakout room, there is one student who needs to report. Oh, as a physiotherapy student, if I hear what the medical students are thinking about our job, well, this is correct and this is not correct. And then we can have discussion. And then we do it the other way around. We ask physiotherapy students, what do you think about when you hear the word doctor? And then another word cloud. So this is one. Second is we have a small movie, 3 to 4 minutes, from a real patient who was talking about things that went wrong in the collaboration between the doctor and the physiotherapist in their experience. And then we have another discussion. And the main aim of this one class is, and that's the name awareness, we want to make students aware that when they enter university or medical school, that the way they look at themselves and their colleagues is based upon societal stereotypes. And so it's not the correct way to look at each other. And in this 1 hour and a half, through interaction with each other and through being confronted with the word clouds that students from other disciplines make of them, they realize, oh, is this how you're looking at me? But then they hear from the others, oh, is this how you are looking at me? And so they realize, oh, the way we look at the other maybe is not the right way. And when they are 18 years old, this is their first confrontation with interprofessionality, realizing that the way they look at the other might not be the right way. And so from the very start of their education, in just 1 hour and a half, we can make them feel first that they are not always right in their judgment. And secondly, how does it feel when someone judges you in the wrong way? And this realization is a very important realization and a requirement to be able to collaborate together. And so this is just 1 hour and a half, online class, nothing difficult to organize. And second part of your question, who is doing the teaching? We do co-teaching. So me as a professor from the medical school, together with a professor from the physiotherapy school, we guide this online session together. And we make sure we agree upon that every now and then I say something like, well, I've been a GP for 30 years and I didn't know this about physiotherapists. So as a role model, showing to the students in front of a professor in physiotherapy that there is still something that I don't know. So co-teaching, making some agreement, role modeling, making students feel what it means to be judged. This is, I think, low cost, low effort, but high output when it comes to the mentality of collaboration. And this was one example. This was the first thing we did, and we still do it in almost the same way. Sometimes we adapt a bit what we are doing in the class, but it's the same. Low effort, low cost, big output. Yes.
So there is another question about costs. The academic environment is quite competitive because the hours meet salaries, and there is, of course, a lot of competitions who gets the hours, and basically who gets paid for this class that is interprofessional communication, because like we think of it as a way to compete for hours, not to collaborate on these hours. And like, how do you resolve this in the financial realm? And how do you create motivation for people to collaborate where naturally they compete for hours?
Yeah, that's a great question, because indeed in academia, competition is everything. Then I come back to what I said in the beginning. You need to find the believers. And we all do things that we believe in. And this, if you work with the believers, it's like an exchange. Like, I come to your school and I teach an hour for free. And then 2 months later, you come to my school and you teach an hour for free. So there is no competition because we have both taught an hour for free, but we have a joint gain because we both believe in the value of interprofessional education. We have contributed to our joint dream. And I know this sounds a bit fuzzy, but so far it works. Also, for instance, in in communication, we have a communication curriculum in medical school. Every year they have like 3 to 4 classes on different topics. Like in year 1, it's interrogating the patient. In year 2, it's bad news delivery. In year 3, it's the difficult patient, whatever. And there was one believer in the communication curriculum who allowed me to adapt one of the classes to interprofessional. There was a class on chronic care. How do you discuss chronic care with a patient versus acute care? I mean, diabetes. How do you motivate a person to do his diet because the effects will only be in 10 years? So this was the focus of the chronic care class. Well, I told this person, a chronic care patient is not cared for by one discipline. This chronic care patient will be meeting 10 disciplines along the way. So why not add some interprofessional communication in this class on chronic communication? So you are right with your question. You need to break into the hours of your colleagues. But if you can convince the colleague of the value, then it's not breaking in, then it's an invitation. But you need the believers, you need to convince the colleague, not that you're taking away 1 hour of his, but that you are helping him to make his class better. Because a student that will be talking to the chronic patient will also need to talk to the colleagues in order to be able to take care of this chronic patient. And this is the rationale that you need to make every time. You need your believer to be convinced of the added value of your input for his class. And I'm saying this now in 2 minutes, not because it's easy, but because it's all there is to say about this. And it doesn't work all the time. Of course, I'm presenting you my successes here, but I have been talking to a lot of professors who say, well, very interesting, but do it in your own hours because I need my time to teach anatomy. So you have these people as well, and you cannot convince everybody, but therefore you need believers in the inside. I cannot go to the nursing school. I cannot even go to my colleagues in medical school who are not believers. But maybe if there are, for instance, 2 professors in cardiology, and I can convince one, then that one can convince his colleague in cardiology to join. And that's think big, but move slowly. And don't be disappointed and frustrated if you get a no for an answer. Just try it later. Just try it through another person. Be always open and authentic. So don't try to trick people into this stuff. Be always open and authentic. Because once I went to the School of Psychologists, and there they say, well, you know, we are kind of interprofessional ourselves because we have different kinds of psychologists. I say, okay, I rest my case. And then 2 years later, they came to me and they said, we hear from the psychologist in the field where our students go on traineeship that our students are not very capable of talking to doctors. And so these clinical psychologists from the field that are training students in traineeship, they came to the psychology school and they say, can you do something about it? And then those professors in psychology came back to me. They said, Peter, you came to us like 2 years ago. Does the offer still stands? And by being patient, they came back. So don't be frustrated and be patient, but keep your bigger picture in mind. If you can go back to the IPEC set of competencies, if you can go back to this slide every time, then you can show that if one of your colleagues is making an effort to even give you 1 hour of time in his class, that it's not the 1 hour that he is giving you, but he's giving you and all the students a step up of a continuum that is built in a bigger picture. And then this professor that is giving you 1 hour has the feeling of contributing to a bigger picture. Okay, good. I'm gonna see. Yes. Another adaptation is Lisa observation. Oh, no. First one, Lisa awareness. So I have been talking about this online class where students discuss with each other these stereotypes. So we have done this for like 3 to 4 years. And what we have added now is we asked every student after the class to write down 1 or 2 things they learned and to translate this in a smart learning goal for themselves for the next year. And what we did then is we asked students to exchange. So the medical students had to give his reflection and his personal smart goal for the future to a physiotherapy student. And a physiotherapy student had to give his reflection to a medical student. And they had to comment upon each other's personal SMART goal, saying, well, this is interesting, but it will not work for this and that. Or, oh, I had the same idea and I formulated it in this way. So then your personal reflection has been adapted by a student from another discipline. And every student had to think about how the other discipline learned something from the same class that they attended. So and they need to learn how to give feedback to each other. So by adding this extra layer, we were able to add another collaborative competency to the learning of the students, again, without changing a lot of the curricula. And what we want to do in some online portfolio is that the students, they keep their reflections plus the feedback from the student from the other discipline in their portfolio. And then the next year, when they have another interprofessional module, they take their reflection from their portfolio from the previous year, they read again what they have written, and they add something. So that even if they only have like 1 module every year, they can build on their learnings of the previous year. So that, oh, was this how I was thinking about collaboration last year? Wait, I learned a lot this year, and they write again. And so in year 6, they have like a track record of personal learning moments on collaboration. And by doing so, we add another layer of interprofessional learning without having to break into the hours of our colleagues' professors. For instance, Lisa observation is in year 3. There we have the medical students going to clinical practice with a general practitioner for 2 weeks. And they are there and they shadow the physician and they watch and learn and observe. And we also have the pharmacy students going to the community pharmacist for 2 weeks. And they observe the pharmacist. And we ask the students before they're going to the field, look, you need to observe your doctor or your pharmacist because you need to learn your job. But while you are there, keep your eye open if the medical doctor is saying something about the pharmacist. Or if there is like a phone call between the doctor and the pharmacist. And also with the pharmacy students, we say, you go to the pharmacy and watch your pharmacist because you need to learn your job. But while you are there, keep your eyes open if the pharmacist sometimes makes a phone call to the doctor to ask or discuss something. And they need to keep notes. And after these 2 hours of observation in the field, they deliver their notes to us. And we collect them and we try to categorize reasons for contact, way of contact, results of the contact, or lack of contact. And then again, we have 1.5 hours online session, co-teaching, me as a professor in medicine, plus a professor of the pharmacy school. And we discuss, we say, look, dear students, we anonymize, of course, and we say, lots of you have mentioned that the medical doctor said, or that, for instance, the pharmacist said, well, this prescription, the dose is not correct for this child. I will just change the dose because the doctor made a mistake. What do you think about this? And then we put them in breakout rooms again. And then you have medical students and pharmacy students, and they say, well, later, when we are in the field, I will not change the dose. I will call you as a doctor to say, why this dose? And so we have the students discussing these anonymized observations with their observation in the field in mind, telling each other how they will do it differently or the same when they grow up. And so again, by making use of these observation traineeship, without doing anything differently in scheduling or organizing things, but just by adding one observation question in advance and then one online session. We don't need to book classes. We just have an online session. Me as a believer and the professor in the pharmacy as a believer, we spend 1.5 hours discussing with these students, and they all learned a lot. And it is, by doing so, it is a deepening of their learning experience from the observation. Because we had to ask, I was not in charge of these observation traineeship. So I had to talk to my colleague who is in charge of this traineeship, a colleague professor, and I say, look, can I ask your students an extra question? And first he said, well, they have so many questions already, this will be a burden. And I say, well, let's have a try. And then by doing so, we could show him that in our class, through the reflection on our single question, they rehearsed all their observations again, and they could add extra meaning to their observation. So the professor who was in charge of this observation also now has a better outcome of his assignment thanks to our additional question that we added. So this is the win-win that you can try to bring into the open, to convince your colleagues to break in this way.
So in a way, it's like almost like giving them an extra lens that they could use sometimes to what they are already doing, right? And like
Yes.
And regularly focusing attention on this issue in whatever they are already doing anyways.
Yes. And then I come back to your openings question. When you talk to people about this, they say, we're already doing this. Well, this professor said, well, our students are there, and of course they hear about other disciplines, so we're doing this already. And I said, yes, your students observe this, but you don't learn from experience. You learn through reflecting upon your experience. So give me the opportunity in my own time, I will not use your time. Give me the opportunity in my time to reflect with your students upon their experience in your assignment. Because we are using your good work to make explicit the interprofessional learning experience to them.
So here comes the next provocative question, and we also have quite a bit of them in the registration forms. And now Natalia puts it here: how do you evaluate progress, and how do you know that this changes something for them?
Oh. This is a very difficult issue. First of all, because scientific literature is not clear about how to assess interprofessional learning outcomes. One of my colleagues in the Netherlands finished her PhD last year on assessment of interprofessional learning. And after 4 years of hard work, her main conclusion was, we don't know. Even simple questions. Interprofessional competencies. Should you assess at the level of an individual student or at the level of a group of students? Because it's a collaborative competence. So we don't know. So all we can do is make some extrapolation from what we know in assessment in general. What we are now doing is, when I talk to you about the awareness class and the self-reflection and the peer feedback from other students in this awareness class, we will now this year collect everything. And like thematic analysis, like you do with interview studies, try to see if, as a group of students, they capture the essence of the learning goals that we intended with this class. If we see that as a group they capture the essence of the learning goals, then we can say, okay, we trust that this group of students has captured the essence. It's not, of course, an individual mark. So we cannot, so this is still a pass or fail for us, because it's difficult to give an individual mark on the self-reflection report. I think it's not worth the effort to do so. But if through this analysis we can say that the group of students captured the essence, then I'm okay with a pass or fail. Because the learning is from the receiving feedback from your peer student and giving feedback to your peer student. Then you have like a rehearsal of the class to be able to give feedback to your students. And the learning moment is there and the assessment moment is there. So I trust a pass or fail. We have, of course, more difficult modules where we do some assessment. And let me first quickly explain the LISA Teams module, because I want to be able to explain how we assess. LISA Teams is, we have groups of 10 students from different disciplines together, working together for 3 days. And in these 3 days, they work on different topics. For instance, they are writing an interprofessional care plan for a patient. They do a moral case deliberation together. They do an incident analysis together. And from each of these 3 exercises, they need to write a report. An interprofessional care plan, a report of a moral case deliberation, and a report of the incident analysis. And we made a rubric. Based upon theory, an interprofessional care plan should contain this and this and this and that. A moral case deliberation, you should take these and these ethical values into account before making a decision. And so based upon this rubric, we can somehow, in a standardized way, give a mark to the group product. And so this group product is in a certain way a result of a group collaboration. So the better the collaboration, the better the product. So they get a group mark. Every student gets the same mark for these group products. Secondly, we observe these students while they are collaborating. And some of the IPEC collaborative competencies of the framework that I showed, we have reformulated them in behavioral indicators. For instance, respect each other's view. We translate it in, if somebody else gives a differing view, you do not turn him down, but you ask questions, something like this. And so with these behavioral indicators, the student group is observed and each student gets an individual mark on his behavior. So then for this LISA teams, we have like a composite mark for each student. Half of the mark is an individual mark through observation through the indicators, and half of the mark is a group mark. So the better they collaborate, the better the group mark, but they cannot hide completely behind the group and be silent and trust that the others will do the work, because they also have like an individual mark for the observation. And this is a more complex thing. So it's trying our best, because literature on interprofessional education assessment is not clear yet. But by our general knowledge on assessment and our general knowledge on education, we think this is a good enough way. And every year we adapt a little bit. But some things are partial fail, like the observation, the traineeship, where we ask them to observe where they see an interaction between doctor and pharmacist, and then the online class. This is a pass or fail. If they attend the class, they have a pass. If they submit their observations, they have a pass. Because we trust that if they observe and they write something down and they discuss in the small groups, then we trust they will have learned something. Because the only way, you cannot have like a written exam on their observations of interaction between professionals. I think this is difficult to make a validated exam. So that's why we trust the process of interaction. And this is what we learn from the theories of programmatic assessment. That is that information-rich feedback is a learning moment. You don't need to assess every small step. You can trust that if you have two people discussing with a certain intensity, that they will have learned something.
I think what touches me is how you speak about your work in a very learning-oriented way. It doesn't sound like you are already enlightened and you have developed this and you are like really sure where you are going with this. But I think what really resonates with me is how you are really experimenting and trying and learning from it in a very humble way. I mean, I just wanted to say that I think this is like the best way to show lifelong learning is that we don't have to be perfect, but we can keep learning.
Well, thank you for this observation, and I take this as a compliment. That your observation that I don't pretend to know everything, because I don't know everything. And this modesty is an authentic modesty, because as a GP, when I address a nurse, then the nurse knows things that I don't know, and I need to the workplace learning aspect. If I have in my practice, for instance, textbook example, a difficult wound care, I call the nurse and I ask her in front of the patient, explain to me what I should do, and explain to the patient. And then I listen, I learn, but there's also transfer of trust. If I can show to the patient that I trust the nurse, then the patient will trust the nurse. And this is in clinical care. And we have the same in educational development. If I want to do this module with the pharmacy students, then I need to listen to the professor in pharmacy, because I don't know where in the development the pharmacy student is. What does the pharmacy student know? Where in his identity development is he situated? So it's a trial and error together. And as we want students to learn from feedback, we should also learn from feedback that we get from our colleagues, teachers, but also from the students. Many of these modules, the first year that we developed them, after the module, we asked a group of students and we did some focus groups. So how did you experience the module? Do you think you learned from it? And how should we adapt? For instance, this observation in the traineeship, we asked 5 medical students and 5 pharmacy students who have done this traineeship the previous year, but without our assignment. And we explored. We said, look, we are thinking about adding another question to the assignment about interprofessionality. What do you think? Do you think it's worth the effort? When you recall your traineeship and we give this assignment, do you think students will be able to report something or not? And then they have changed a bit our question, because if you ask it like this, you will probably get some empty pages. But if you ask it like this, or you focus on that, in our experience from previous year, we have seen a lot of stuff that we can add to the report. And so the students helped us create the assignment for their fellow students for the year after. And this is how I think when you don't know what to do, you should ask people who know.
Ask the students.
Ask the students.
Peter, thank you so much. Maybe last question, and we will probably need to wrap up. But there was a comment in the chat from Olena, and she basically, she is a bit skeptical. At least that's how I take it. Olena, please correct me if I'm wrong, but basically, quote unquote, I believe that it should be a separate educational program for interprofessional integration in healthcare. So I took it as a skepticism in terms of weaving it into the program, but actually she thinks that it has to be a separate training program. And I just wanted maybe to ask you to elaborate maybe what are the arguments for or against incorporating it into current training or developing a separate one, and then I will wrap it up with a summary.
Okay. I think this is a great question. A question that you could have asked at the beginning or now. And I cannot say if the person who asked the question is right or wrong, because I don't know. One reason that we started like this is the pragmatic reason. I don't have room for a separate curriculum. I cannot say I want 20 hours every year in every curriculum. So the pragmatic reason is try to weave it somewhere in. I do believe some weavery is necessary. When I compare to communication, we teach medical students in role plays how to talk to patients, and they all perform brilliant. And then we bring him to the ward with a real patient, and they forget all about their communication techniques. They see patients, they start to panic, they ask stupid questions, and they forget what they learned about communication. So the integration, we cannot expect students to integrate themselves completely. We need to teach in an integrated way. The same with palliative care. You can have a palliative care curriculum, or you can weave it through in, saying, ask the cardiologist in his lecture on heart failure to spend like the 5 last minutes of his class on palliative care in terminal heart failure. And this is integrated teaching. Or you can have the cardiologist have his cardiology stuff, and then the palliative care physician, oh, well, if a cardiologist doesn't know what to do, bring him to me and we do palliative care. So this integration needs to be at the teaching level, because students cannot completely integrate themselves. However, the person who asked the question is also right, because there always is some basics that you need to know. Like my example of communication, you need to teach in an integrated way, but you need first some basic communication skills before you can teach it at a more advanced level in a more integrated way. So ideally, I completely agree with the colleague who asked the question. You should have some classes specifically designed for interprofessional collaboration with the basic concepts, the basic attitudes, the basic communication skills, a basic reflection on ethics in collaboration as a separate class and entity. And the more advanced levels, I think, as far as I know now, are better taught integrated, because I'm not sure students can integrate themselves. And I would be interested, because I very much like the question, if this differentiated answer can be accepted by the colleague, or how she thinks about this.
Олена Скрябіна, якщо ви ще тут, то дайте відповідь, будь ласка, наскільки ви задоволені.
Olena Skrabina, if you are here, we want to hear your feedback. Are you contented with the answer that you received from Peter?
Thank you very
We
much.
need you.
I hear, maybe, але в наших освітніх програмах
Within our educational programs, yes, we have the interdisciplinary integration, and our students, yes, that's the way how they get the hang of it consecutively and in an interdisciplinary way. So I do not know how it is abroad, but having a chance to communicate with the teachers who are teachers in the medical school, for example, but our faculty has to be pharmaceutical, and for example, I'm sorry for my cat, so those who need, yes, they communicate with doctors. Thank you for the answer, but as for now, I see it as the free work, I mean, free of pay, but it looks like, yes, our teachers, they add such interdisciplinary things. It is what we already have. But if some teacher, for example, I mean, theoretical teacher wants to go into the simulation center, for example, we have both clinicists and theoreticians working in this simulation center. So it also like interdisciplinary collaboration, I would call it. And yes, we do not have separate educational program, but it's also about time, the time which teacher is not get paid for, and that's pity.
Yeah. Okay, I agree. Thank you for the answer.
Наталю, давайте дуже короткий коментар, бо мені потрібен час, щоб зробити
A
підсумовування.
very short comment because I have to wrap up. I will be brief here, yes. From what I heard, I can say that we can have this, hidden curriculum. We can make it visible. So we have to explain our students. So when and where we talk this over, and then they would be better in terms of reflecting and in terms of the takeaways. So because sometimes we cover some, but it just fades away. But such thing will make it happen.
Дякую дуже. Наталя почала мене вже підсумовувати.
Natalia started to wrap up
Okay,
instead of me.
Peter,
All right.
I want to start summing up. Is that all right? Or would you like to say something as a final word?
No, I mean I'm happy that the term hidden curriculum has been mentioned, because I think this is a very strong neglected part of our education, and you see it in hospital surgeons and cardiologists and internists, but you also see it in between professors from different schools and students. They see, they know, they feel. And being able to discuss this, to talk about it, this is a great interprofessional learning opportunity without having to schedule major curriculum reform. So the word hidden curriculum is something that I will put on my slides next time that I give this presentation. So thank you for adding that.
Thank you. Okay, I made some notes, and I think I would like to summarize our conversation of the last hour and a half in maybe 7 main blocks. Peter started with talking about the changes that have been happening in the profession and also in the context, about the increasing age of patients, about more informed patients, and on the patient side, and also about the changes in the health workforce, and how there are fewer people that work, and there is more load, and how they can interchangeably do certain things, and this requires more coordination and requires more learning. The second block was really about how the interprofessional coordination and collaboration can improve the quality of care, how it has a positive impact on its efficiency and better use of workforce, and also helps decrease burnout and increase job satisfaction, and also helps achieve these 5 aims of healthcare improvement. So in a way, Peter gave this big picture of like the big dream, where the impact goes. And he also mentioned that there is a summary of competencies that can be Googled as IPEC. And the IPEC has basically 4 key categories and approximately 10 subcompetencies under each category to look at. And then Peter moved on into implementation, so how to do it, and the key words here were think big and take small steps. And I think this humbleness about small steps has been like one of the key focuses of the second part of the talk. I will come back to that. And from this implementation strategically, Peter mentioned a couple of things to get support from the top, to create joint committees, and also to involve those who are not involved and share these small successes. And I think the biggest highlight in this part was about finding the believers and making small steps to collaborate with them. And basically build on these successful small collaborations and kind of spread them like a virus, also with the help of these believers. And then in the 5th block, and we kind of jumped in and out of it a little bit, but I have been writing down in terms of how, like, what are the instruments and how you really do it in the classroom. And I have noted a couple of things that I will just really list about building awareness through co-teaching, role modeling, feedback, reflection, both individual and also group reflection together, joint reflection, and integrating it at the teaching level. And you also talked about it a bit later, but I kind of put it as a as the key instruments that could be used to do it at a practical level. And then we had a section on assessment, and Peter mentioned how complex this is and how little there is in science about how to assess this kind of learning, and also shared what solutions he and his colleagues have found. And basically he talked about the thematic analysis of people's portfolio, and also about combining group and individual grades for the interprofessional care plans that is developed by groups, but also how they use competencies as and behavioral indicators to assess individual performance in class. And I think last but not least, that was really a highlight of the session. Also throughout the session, I would put it as this authentic modesty or humbleness that Peter shared this with, and I also felt like it was kind of throughout every step that it's about really, and I think this is like the core of this competency is your willingness to learn from others and from other professions, and openness to a conversation, not from top down, but actually like with a certain curiosity and humbleness in the way that you approach development of these methods, trying and experimenting. I felt like this humbleness is like one of the core things that you really are doing also in your work with other colleagues and with students. And you talked about the learning from other professionals and learning from students and learning from feedback. I think like if I were to to summarize all of this, it will basically about how to weave authentic humbleness into the learning process, and keep it forever. Yeah, so thank you so much, Peter, for finding time to prepare for this with us and also for sharing. And I'm also really glad that our Ukrainian colleagues managed to share about their experience, and I think it's really important also to learn how to frame the value of this learning in your own eyes, but also in the eyes of the people that you work with. And I think a lot is already being done in Ukrainian schools, and we are really grateful to learn also how to frame the value of this learning from the facilitation perspective, and how to highlight it for the people in a way by giving them this additional lens to look the world with. So thank you so much. We will have I will probably announce our next meeting. The next meeting will be with Orit from Tel Aviv. I think some of you have already been to our meeting with her in May. Orit has done a lot of work in using a reflection, like self-reflection, as a teaching tool. I mean, Peter also referred to using self-reflection as a learning tool. So I've asked Orit to talk a bit more about how she uses self-reflection in her teaching, and this will be our November meeting. So please stay tuned, and you will learn about the next date and time from the emails and from the Facebook posts. And thank you so much for being with us. Дуже вам дякую за те, що ви доєдналися, і за те, що вам цікаво. І я вже бачу тут людей, які приходять кожного разу. Дуже радію, що
I see here people who are joining every time, and I'm very glad to have you each time with us. Thank you very much. These are your big steps, small steps towards big outcomes. So see you. Thank you. Thank you. Thank you very much for the lecture. Goodbye.
Thank you. Bye-bye. Good luck, and always reachable to talk.
Bye-bye.